Welcome to the One Piece Implant Mentor podcast. I am Dr. Andrea Joy Smith, your host and mentor. I am a general dentist in private practice for nearly 30 years. But for the past 16 years in my practice, I have focused primarily on placing and restoring one piece dental implants. This unique podcast will not only give you an inside look into my practice and similar successful one piece implant practices, but you will also meet the true pioneers in one piece dental implantology. Joining me on the podcast today is one such pioneer, Dr. Thierry Giorno. Dr. Giorno is an accomplished dentist and scientist. He is the founder of Interlock International Biofunctional Materials, and as such, he designed the implant that I use in my practice every single day. Interlock implants are sold all over the globe. A few years ago, however, Dr. Giorno sold Interlock International to the implant giant owned by Henry Schein, BioHorizons. We could easily have a discussion for hours about all of the inventions in implantology that he has done, but for the purposes of this interview, we're going to focus on the one piece dental implant. Dr. Giorno, welcome to the podcast.
Thank you.
Dr. Giorno, I know that Interlock International manufactured both conventional and one piece dental implants. What motivated you to develop the mini drive lock one piece dental implant?
Actually, this goes back a very long time when I just graduated, I just met Dr. Leonard Linko from New York, who is a true genius and the pioneer of implant dentistry in the world. And, I don't want to go through the story, it would take too long, but he showed me what he was doing in the 60s. So it's a very long time ago. And he was using a mini dental implant. It was a 1.8 millimeter dental implant. It has been developed by Dr. Cherchev, a French surgeon. And actually, he showed me pictures of some live surgery they were doing in the hospital in the 70s, placing one piece implant. And the procedure was exactly what you are doing today in your practice. And I thought that that was very interesting. So we developed this mini driver lock implant, which was basically more or less the same procedure with one difference. We placed a no ball on top to stabilize lower denture. That was the purpose of this implant.
Other than adding the O-ball, what other design considerations did you incorporate into the development of the MDL implant?
So, what we did, we made it much stronger because at that time the implant was in stainless steel and it was very stiff and it so we made it in a titanium alloy. We increased the diameter to 2.0. We also made a 2.5 available, so the implant was very sturdy. If I remember correctly, it takes about close to 70 newton centimeters to break the top of the implant. So the implant was very safe to use. We also made some changes in the thread in order to make it easier to insert. And also, what was very important, we pay attention, a lot of attention to the implant surface. We developed the ocean surface, which is a very, very sophisticated surface that makes the implant. Uh, I have to weight my words carefully, but we can say that basically the implant, the bone bonds to the implant.
I certainly have some questions about the Alcyon surface, and we will delve into that a little bit later. But first, One of the things I want to touch on in regards to the implant design is I think that the beauty of this O-ball implant is that there is a larger diameter version, the Milo implant, that is supplied in diameters of 3.0 millimeters and 3.75 millimeters. What was your motivation for developing the Milo implant?
The Milo and the smaller MDL, they don't function exactly the same way because the 2.0 and the 2.5 implant basically they go in the
Mhm,
bone with minor or
mhm.
almost no osteotomy. They play on the bone elasticity to really self thread themselves in. Uh, the Milo being a 3.0 millimeter implant, it's too big. You cannot force the bone to expand that much. So you need to do more than a pilot hole. You need to do a full osteotomy. So the behavior of this implant is a little bit more like the conventional implants. Uh, but it makes sense that if you are less invasive, you're going to have better response, you're going to have faster healing, and so forth. So and this is true for any kind of surgery, could be abdominal surgery, plastic surgery, any kind of surgery. If you don't rip open the patient, he's going to heal faster and better and with less pain.
Yes, that's one of the things I love about this implant protocol is that you do not have to completely disrupt the blood supply. And that's really good to know about the Milo implant, its function more as a conventional implant, because I place those implants more often than not in the posterior maxilla, where the bone is a lot less dense. And I do drill a larger osteotomy, and I follow the progression with the drills. But I still underprep the bone in order to ensure that I achieve the proper torque. Is that a good practice?
Yeah, obviously this depends on the bone density. If you have D4, D3, D4 bone, you can undersize your osteotomy a lot. And actually, when you're going to place your implant, you are going to condense the bone, like you will be using your implant as an osteotome, basically. But never do that in dense bone because overstressing the bone is bad. Like if you compress the bone is going to respond, and you're not going to like this response. So high torque
Mhm.
is your enemy, actually. Each time you go over 45, 50 Newton centimeters, that's bad. It's better to remove your implant, drill a little bit bigger, and replace the implant. Torque, torque is not always good.
I could appreciate that point because some may be
Uh-uh.
under the impression that a higher torque is better. The third preset on my implant motor torques at about 60 Newton centimeters. But I learned from you that that is not ideal. That's not always what I want. Would you say that it's ideal if the implant reaches its final position at a torque of about 30 to 35 Newton
Yeah,
centimeters?
that's perfect. The, if you get it, let's say between 30 and 45, that's max. You don't need more than it's not that it will not necrose right away, but you will compress it so much that you won't have the blood supply to have a very nice healing.
Now, let's circle back to that ASEAN surface. Most, if not all, implants are manufactured with a surface coating, presumably to enhance osseointegration. Can you tell us more about the ASEAN surface that you developed for the MDL and Milo implants?
Actually, we developed that for all the intralock implants. But first of all, that's not a coating. Because coating means that something is added to the surface. Uh, Actually, we can say that nothing is added, but I will explain more in details. It's more of a subtractive process, but in this whole process, uh, some particles of calcium phosphate get incorporated, but if you look with the highest possible magnification, you will not see any particles in the implant. It's at the atomic level, those calcium phosphate atoms are incorporated into the oxide layer of the implant. And so this is the first thing which is very important. The second feature that's very important is the roughness. Uh, Roughness is something very important. In the literature, you can read that the best roughness or RA is between 2 and 3 microns. This is not science because ru- the roughness analysis is function of the magnification you are looking at. If you have a microscope that shows you magnification with this range, you're going to be able to measure the peak and the valleys on your implant surface. But what if you increase magnification? If you increase magnification to 100,000 times magnification, you will see that most of the implants on the market, if not all, are what we will call nano smooth. At the nano level, they are flat as a mirror. And the beauty of the ocean surface is that at the nano level, they show exactly the visual, they show exactly the same peaks and valleys like if you were looking at a much lower magnification. This has a name, it's called fractal. Google the word fractal and you will learn a lot. It's very, very interesting. The nature by essence is fractal. So you have structures, they are repeating themselves just like the Russian dolls. You open a big one, oh, there is one inside. But you know what? You open, there is another one inside, and so forth until very, very, very tiny, all the way to almost the molecular level. So basically, we did not invent anything. We just tried to mimic nature.
The Russian doll analogy paints a very clear picture of how things get infinitely smaller, yet maintain the exact structure, and is not nano smooth. How did you develop and test the efficacy of the ASEAN surface?
So, many, many years ago, I was in my 20s. I worked for some time for a company manufacturing paints and varnish. And I learned a lot about the physics and chemistry of primers. And when I so after that, I got into implant dentistry and stuff like that. And I remember I was watching the first surgery. I don't want to mention in which university, but I was looking at those eminent doctors placing what was like the best implant at that time. And I saw them place the implant, and I saw the blood making bubble around the implant. I told them, but the blood is not wetting the implant. Your implant is not going to function. They looked down at me like, but you don't know. Professor Brunemark has 30 years of studies on that. I say, you know what? Sure, I don't compare myself, but it's just common sense. If the blood doesn't wet on the implant surface, how do you expect the healing to come later on? Of course, they never answered. But so, with this surface that we have developed, the fibrinogen, which is the first component within blood, is going to wet the surface so nicely, and the fibrinogen is going to polymerize into fibrin, and this is the first component of healing. So this is going to stick to the bone like there's, I mean, it's going to, the fibrin is going to stick to the implant surface like there's no tomorrow. And when bone is going to heal, there will be no space between the implant and the bone. So it will make a perfect surface. And throughout those years, for so many years, when you are a company in the US, of course, FDA registered, FDA approved, you need to log what is called kappa, which is like the uh, events, like problems, stuff like that. They all come to you and they need to be registered. So uh, what's very interesting is that for 10 years the feedback we had from the customers on on peri-implantitis was close to zero. And actually this created some issues with the regulatory, because sometimes when we have audits, the auditors did not believe us. They thought that we were frauding them, we were not keeping our
Hmm.
data in place. I say, I'm sorry, that's all we have. Do you want me to create failures? We don't have them. I'm sorry.
That is great information to know about the ASEAN surface. Do you know of any other implant manufacturer that has a surface even similar to the ASEAN surface? I've not heard of any. So, in my opinion, this really sets the implant
So
apart.
absolutely, absolutely. There's some literature out there. There are some articles by Dohan and Coelho that have been published. The first one, it was comparing surface of, I remember the first one was probably 12 implant surfaces. And there was another article comparing to, I believe it was 64 implant surfaces. So they were looking at the profilometry at different magnification, all the way to 100,000 magnification. But they were also doing X-ray spectrometry to analyze for contaminants on the implant surface, which is another very important feature. Uh, and none of them showed nanoprofilometry, which means that if you look at 5,000 time magnification, they all have profiles. But if you increase to 100,000, they are smooth as a mirror. And that's a very big differential.
Well, Dr. Journal, you have certainly enlightened us on the superior features of the mini drive lock implants you developed at Interlock International and that are now sold by Shack and First. I am really confident that I am providing my patients with the most technologically advanced one piece implant on the market. I think that providing a one piece implant solution for my patients is a very invaluable service, not only for denture stabilization, but for other applications as well. What would you tell dentists who want to learn the one piece overdenture placement protocol, but are not yet placing dental implants?
What I would recommend is to start walking before they run. So the first procedure would be to stabilize lower denture with 4 MDLs.
I
Uh,
agree.
Actually, I remember the first time I did that for a patient, I was amazed by the patient
Definitely.
thanking me for what I did. And I was thinking, you know what? Sometimes I do such complicated procedures, 3 surgeries, the patient spends a fortune, and I don't see this level of thankfulness in his eyes like I see for this patient. It was like a 40 minutes procedure. It cost very little money, And the patient was so thankful. And that, I still remember that. So, this is the most rewarding procedure for your heart that you can give the patient, because the patient is so thankful to you. You change his life. He's been miserable with floating denture and itching denture. And with this little procedure, less than an hour, he goes home and he bites into some hard food. And this makes you feel good.
I too have had patients who are very grateful and thankful after receiving the procedure. I've never had anyone hug me after completing a root canal on tooth number 15,
Exactly.
but the one piece implant procedure definitely gets that thankful response. I like your advice for dentists starting out to start with the lower denture stabilization. That's actually very sound advice. And what would you say is the most important step in the entire protocol?
The key, like for any procedure, is treatment planning. Plan your case before you you start numbing the patient and do the procedure. Plan your case. It's going to save you a lot of trouble. And and my second recommendation would be, after you gain confidence and you start placing implants all over the place, do not place so many implants that the patient doesn't need. You don't need to place one implant per tooth. You don't need to do that. I see that too often. You don't need to do that, because you are going to make your prosthetics more difficult.
Well, I have to say, I am guilty of over engineering my cases, placing that one or two extra implants. So it's good to know that because of the quality and the efficacy of the implant, over engineering, while in some cases might be a good idea, is not necessarily better. And I understand that restorations will definitely suffer if you have an implant in a location where you could not adequately restore it. When you were placing one piece implant restorations for your patients, were you using one piece implants for fixed appliances as well?
Now, you can do that. It's not, like for example, for lateral incisors, when you don't have much space. I mean, this is a great indication. Uh, but there is not one answer fits all. Depends on the patient, what he wants.
Yes, I once had a patient who was seeking full mouth fixed restorations, and the 2.0 millimeter implant was too large. So I happened to have some implants left over from another company that no longer makes mini dental implants. Usually, I like to use implants that are much larger, but in this case, the bone was very, very thin. And so I like to describe it to my patients like this. I tell my patients, I have an implant to fit your bone rather than me having to expand your bone to fit your implant. And so this is one of those cases where I needed a smaller implant in the posterior where I normally would not put there, but this patient had very little bone.
In this case that you are describing, because the implant is so tiny, you need to place a little bit more.
Yes, that's exactly what I did. That's my
Yeah.
over
No,
engineering.
but this is not over engineering then. That's correct engineering.
Dr. Journal, thank you for joining our podcast. I look forward to speaking to you again about your many other contributions to dental implantology and restoratives that you've created. The future is bright for one piece implants.
Thank you very much for the invitation. And next time we will discuss the restoration part, which is equally important, because the patient is interested with his teeth, not so much with the implants that you place.
Correct. And the purpose of this podcast is to spread the word about one piece implants. And I am so happy you granted me this interview so that we could spread the word about these one piece implants. Thank you for joining us on the One Piece Implant Mentor podcast.
My pleasure. Thank you.
Thank you.